Everyone, Dr. Kuniak here with a supplementary video lecture. So we're not meeting this week in person, so I wanted to create a video lecture for, to add to the content of the course. We talked last week in the live meeting about ethics, and so I hope you've been thinking about ethics in the interim here. This week, the readings focus on the counseling process, assessment, diagnosis, approaches to clinical mental health counseling, and then managing suicide risk, crisis, and disaster. The managing suicide risk topic I'd rather do in person. So during our next meeting, I will bring up ethics again so we can go through that scenario because I didn't want to lose, I didn't want to rush it last week. And then we'll move into suicide risk. So I thought that as kind of an interim lecture, it wouldn't be bad to talk about assessment and treatment planning and how we approach counseling. So I'm going to try to, and we can certainly, further this conversation in our next meeting, because I think that wrapping your head around how you approach the counseling process can have its own challenges. And so it makes sense to talk about this in an intro lecture or in an intro course, because you're going to talk about it again in theories, you're going to talk about it again in your skills classes. But having an idea about how we approach the counseling process can be helpful. So I was taught really early on that, I think that, let me back up and say, I think that, at least for me, I thought that I would go into my first session and I would just ask my client what was going on, what brought them in, and then we would just start talking about that. And the counseling process would just naturally evolve out of that. I can tell you that sometimes that does happen, but it's actually very rare. More often than not, my clients will come in with some sort of presenting concern, but they really don't know where to go with it, which is why they're coming to counseling in the first place. They know what's wrong, but they don't really have any idea about how to make any sort of improvements in their life. And sometimes my clients will come in and not really have an idea about what's going on in the first place. So I learned about treatment planning really early on. So the idea that I take their complaints and then I try to figure out goal areas that we can work on to make progress in our counseling sessions. So if they come in talking about feeling anxious or depressed, then I present to them some goals that might be, minimizing feelings of depression, minimizing feelings of suicidality, reducing feelings of anxiety by increasing feelings of control, things like that. But I was presented with the idea in some of my first roles as a counselor with this idea of using assessment tools. I was familiar with assessments from my undergrad psych courses. I started working as a counselor while I was completing my master's degree. So I had some exposure to assessment, but I had this idea that we used assessments for very specific things. So we used assessments, published and pieced together assessments specifically for looking at anxiety, or specifically for looking at depression, or specifically for suicide risk, or maybe specifically for resiliency or something like that. I didn't have a really clear understanding of how we might use assessments to figure out that a client has any of this stuff going on. I also didn't understand how that assessment would lead to treatment planning. So a formula I was presented with in my master's program was the idea that good assessment leads to good treatment planning, and good treatment planning leads to good treatment. And so that may make sense on the surface, but I struggled with that for a while as a counselor. I got the idea of how that might play out, but I wanted to get to the work so bad, like that was what I thought I had to do, that I would try to rush the assessment process and I would try to rush the treatment planning, try to get those things done so that I could start working with my client. You can use assessment and treatment planning as interventions. So you can use assessments, maybe one session, to just get a conversation going about what's really going on in the client's life. So use the assessment tools, whether they be formally produced and published assessments, or whether they be something more guided, that you just find online, or I keep a folder of assessments when I find good assessments on my computer, depression scales, anxiety scales, things like that. I've worked on my own assessments too. Just when I start doing something repetitively, I think maybe I should write this down and use this more formally in the future. You can always do that and add, eventually maybe you publish it and it gets added to the clinical literature. So anyway, But you can use that. And then when you do treatment planning, you can add that as an intervention. So my treatment planning sessions, when I propose my goals, usually involve like talking about them and saying, this is what I'm seeing going on. Do you agree with this? What's different? What do you, how might you word it if you were writing it? Okay, this is what I can help you with. Does this make sense to you? Okay, what do you need? Let me see if I can give you that. And that becomes kind of the treatment planning process. And then we get into the work. So if you do those things well and assess well and treatment plan well, that'll help guide you so that when you're in session and you're thinking, this really isn't going anywhere, this doesn't really make sense, you can go back to your treatment plan and say, now we agreed we were going to work on this thing, but it doesn't feel like we're working on that. Is this still important, or is there another goal that maybe fits better? And if this is still important, why are we talking about this? Okay, well, maybe this is a new goal area that we want to approach, or maybe this is a deflection. This is preventing you from getting to the stuff that you really need to cover. Or maybe it's, this is kind of first and it's helping to lead to this conversation we had. But you can go back to the treatment planning and you can go back to even back to the assessments. And so this process can be kind of a living, breathing, back and forth sort of thing. So I feel like we've covered a lot of stuff. Maybe I need to try to figure out what else is going on, because you're telling me that you still don't have relief, or maybe this issue is taking care of itself, but you're realizing that there's something deeper that's going on, or maybe I've picked up that there's something deeper that we're not talking about. And so we can kind of reassess and retreatment plan and update all of that and move on to more and hopefully beneficial treatment. So I think that's part of the process of getting things started. The other thing I'll say to you is I really enjoy teaching theories of counseling. And if I don't have you in theories of counseling, that's okay. For sure, we have many qualified professors in our program to teach theories. But I really love teaching theories because I think that figuring out what theoretical orientation you most closely align with can help to guide you. Later, I had a professor who used to say that at the start of our practice, we can't afford to be eclectic. But once we've been practicing for some time, we can't afford not to be. And so I think students will come in and they want the skills, they want the bag of tricks to try to work with their clients. But if you don't identify closely with a theoretical orientation, an anchor around that, when things get tough, you'll just kind of piecemeal out these interventions that you've learned, and they won't work as well because you're just kind of trying to throw things against the wall and see if they function. Instead, it can be helpful when things get tough to say, I wonder what Carl Rogers would have said about this, or I wonder what Virginia Satir would have said about this, or I wonder what Salvador Minuchin would have said about this, because you then have these you can then dive into humanistic and person-centered theory, or structural family therapy, or solution-focused brief theory, and when you then say like, okay, well, this is what Virginia Satir might say about this, this is how she might think about this, then that can help lead you to some of those interventions that she might have used, and move off of those. So I think that it's very common for students to want the tricks. And I get that. I really, really do. You want to know what to do. What's A plus B? What's the C? So my client tells me this, and I know I need to do this, or I assess this. So what's the intervention? And you can't really do that. There's a science to the work that we do, where this stuff gets tried, and then it gets tested, and then it gets published in research. And so we do have data to back the work that we're doing, but there's also an art to this. So, I can teach you how to use an assessment tool, and I can teach you what the different theories are, but then how you apply that to your clients is the art. And the only way to get really good at that is to practice and to make mistakes. We expect you to make mistakes. I make mistakes all the time still, and I've been doing this for, I don't even know anymore, well over a decade. I've been a professional counselor. I don't think I've hit 2 decades yet by any means, but well over a decade I've been doing this, and I still make mistakes, and I learn from them. And and you can apologize and walk that back. That's a process called rupture and repair. There are times where we say stuff that just falls flat and it doesn't work, and that's fine. You just kind of move on to the next thing. And there are times when we say something and it has an unintended consequence and may upset our clients. That's the rupture part. Repair is when we apologize, walk ourselves back, talk about how we're human, and model for our clients how to correct errors. So anyway, there's a lot to say about this. I'm certainly happy to continue this conversation in our live meeting. I wanted to give you an idea, though, of how assessment and treatment planning works. You know, if you are working at an agency that receives any sort of insurance compensation or you know, state or federal funding, which is going to be most of them, they're going to want you to diagnose on day one. And so it's okay to diagnose a client and then to change that diagnosis later if you're wrong. I think that that's another thing that happens is students will finally get comfortable with assessment and treatment planning, but then they're afraid that, well, you know, and this will happen in skills classes where we ask you to try a diagnosis out. I'll have students who go 2 or 3 sessions and still haven't rendered a diagnosis, and they say they don't have enough information. Well, you're not getting paid. I mean, in our skills classes, you're not getting paid at all. But if you are working in the field and you're doing these sessions and you're not rendering a diagnosis, you're not getting paid for that. So it's okay to put a diagnosis out there. We don't use, in counseling, we don't use diagnoses to drive our treatment. A diagnosis just becomes kind of a method of gathering together the observations I've made and giving it a label so that if another person was looking at this, they'd be able to say like, okay, these symptoms make sense to me based on the thing that you said. But you can always uncover more information later and just write it in your note and amend the diagnosis. You don't have to be married to it. Just like you don't have to be married to a particular theory. Some of the theories that I played with early on in my career, like I really loved the idea of person-centered therapy with Carl Rogers. I thought that was going to be my, because it's very nurturing and enriching, and it's kind of exactly like what you expect counseling to look like. And I noticed a lot of students gravitate towards that. I don't use a lot of person-centered anymore. I certainly have kept kept some of the key components of it, like unconditional positive regard, and you know, the discrepancy between the real and ideal self. I use those with my clients a lot, but I wouldn't say that I'm very Rogerian or very person-centered anymore. I'm much more existential counseling oriented. I use a lot more structural family therapy. I use Gestalt more than I use person-centered therapy. So like as your career moves on and you start learning things and you start feeling what your style looks like, you may shift, and that's okay. But it's helpful to be anchored to something at the start. You know, I used a lot of person-centered early on in my career, and then I found out that it didn't work as well with the clients that I was working with. So I started to kind of pick up on other things that worked out better, and I changed my philosophy. So anyway, all that to say, there's a lot that goes into how we orient ourselves with our clients, and I'm happy to talk about that some more. But I wanted to give you a sense of what's out there to start with. Okay, so great talking with you all, and I'll see you in our live meeting next week. Certainly reach out to me with any questions or concerns.